All right, imagine this. You're in a crazy busy emergency room. Someone's just come in with a really badly twisted ankle, and the doctor has to make a snap judgment. Is that a simple sprain or is it actually broken? Well, today we are talking about the Audible Rules, a brilliantly simple checklist that totally changed the game for ERs everywhere. Let's dive in. We've all had that heart-stopping moment, right? You take one wrong step, you fall, and the sharp, searing pain just shoots through your ankle or your knee. And the very first thing that pops into your head is that one dreaded question. Oh no, is it broken? And that question, well, it usually leads you straight to the emergency room. And if that's you, you're definitely not alone. This exact scene plays out thousands upon thousands of times every single day in ERs all over the world. So for the doctors and nurses on the front lines, the real challenge is figuring out, okay, who really needs an X-ray and who just needs to go home with some ice and put their feet up. But here's the kicker. For every 100 people who show up at the ER with these kinds of injuries, it turns out only about 15 of them actually have a broken bone. That means a huge number of X-rays are being done on people who, frankly, don't need them. And that just clogs up the ER, drives up costs, and exposes people to radiation for no reason. So this is the exact problem that a team of researchers up in Ottawa, Canada, led by a Dr. Ian Steele, decided to tackle back in the 90s. They just knew there had to be a better, smarter way to make that call. And their big idea? Something called a clinical decision rule. So what in the world is a clinical decision rule? Well, just think of it like a really smart checklist. It's not some robot making the diagnosis. It's a tool based on tons of evidence that helps a doctor use their own expertise and apply it consistently. The whole point is to aid their professional judgment, never, ever to replace it. And, you know, the real beauty of the Ottawa Rules is just how simple they are. They take this really complex decision and boil it down to a few basic checks. At the end of the day, for both ankles and knees, they're really just trying to answer two main questions. 1, where exactly does it hurt? And 2, can you actually walk on it? Now, the rules for the ankle and the knee, they aren't identical, but they're built on the same foundation. For ankles, it's all about checking for pain and tenderness in very specific bony spots. For the knee, things like your age and how much you can bend it are more important. But you see the common thread, right? That big question for both is, can the patient put weight on it and walk? Let's start with the ankle. For the ankle and foot, the logic is super straightforward. A doctor only needs to order an X-ray if the patient has pain in that main injury area. And they either feel tenderness when the doctor presses on one of 4 very specific bony landmarks, or they physically can't take 4 steps, even if they're limping. If you can walk and those spots aren't tender, a fracture is incredibly unlikely. The knee rule makes just as much sense. But here, an X-ray is needed if a patient has any of these things. Are they over 55? Is the tenderness just on the kneecap or this one spot on the side of the leg? Can they not bend their knee to a 90-degree angle? Or, just like the ankle rule, can they not take 4 steps? If even one of those is a yes, then it's time for an X-ray. Now, of course, this is really important. The rules don't apply to every single person in every situation. They're not for patients who might be intoxicated or have other painful injuries that are distracting them, or, have so much swelling the doctor can't even feel what's going on. In those cases, the doctor's own judgment always comes first. Okay, so the idea is really elegant, it's simple, but this is medicine. The only thing that really matters is, does it work? Is it safe? Does it actually do what it's supposed to do? The evidence has to be there. Well, the results are kind of staggering. For ankles, the rules have a sensitivity of about 98.5%. The knee rules are close to 100. Now, sensitivity is the magic word here. It means the rule is incredibly good at catching anyone who might have a fracture. It's like a smoke detector, right? It's designed to never miss a real fire, even if it means it might go off for burnt toast once in a while. So we know it's safe, but is it efficient? Oh yeah. When ERs actually use these rules, they end up doing about 30% fewer X-rays for these injuries. That is a massive drop. That means shorter wait times, lower costs, and less radiation,
all without putting patients at risk.
And this quote from Dr. Calvin Huang really nails the whole point. He says, the rules are great for ruling out a fracture, but not so great at ruling one in. Why? Because of those false positives. It'll send some people for an X-ray who turn out to be fine. And that's the whole idea. It's not trying to perfectly diagnose the break. It's trying to safely, confidently identify that huge group of people who don't need an X-ray in the first place. Here's another way to look at it. On sensitivity, that's its ability to rule fractures out, the rules get an A+. They almost never miss. But on specificity, that's ruling fractures in, it's, let's say a C grade. And that's because of those false positives we talked about. But in an emergency room, you'd always pick the tool that has A+ safety, right? So let's just zoom out for a second. What's the real-world impact of this simple idea? It's really a story about how one clever checklist can lead to healthcare that is just plain smarter, faster, and safer for absolutely everyone. I mean, the benefits just ripple outwards. For you, the patient, it means you're in and out of the ER faster with less radiation. For the hospital, it means the ER isn't as clogged so they can focus on the most critical patients. And for the whole system, it just saved money. It's a win-win-win. At the end of the day, the Ottawa rules are just a poster child for what we call evidence-based medicine. It's the perfect example of how really solid research can be turned into a simple, practical tool that helps doctors do their jobs better, improves things for patients, and just makes the entire system run more smoothly. And that kind of leaves us with a pretty cool question to think about.